Hi, everyone. Welcome. I'm Hemi Tawarson. I'm the Executive Director for the National Academy for State Health Policy, or NASHP, as many know us. I'm so pleased you're here today with us. I think we had many registrants, over 500. So we'll see if everyone comes, but we have a really robust group here for this webinar. And I have just a couple of things to share before we get into the meat of all of this. First of all, I wanted to thank Arnold Ventures for supporting this webinar, as well as all of our work here at NASHP related to this topic. We really couldn't do the work without their partnership. We also are so pleased to be collaborating with the Center for Medicare and Medicaid Innovation. And really what we're here to do today is to share more information about the new Advancing All Payer Health Equity Approaches and Development, otherwise known as the AHEAD model. Many of you, I think, participated perhaps in a webinar last week that was hosted by the Peterson Center on Healthcare and the Milbank Memorial Fund in collaboration with the Innovation Center. And that webinar highlighted the model's requirements to set and monitor a total cost of care target and spotlighted some state efforts to date. Today, we're going to focus on two of the AHEAD model components: hospital global budgets and investing in primary care. So I'm really excited for the fantastic panel that we have lined up. I'm going to just say a few words about them, but their full bios are available on the NASHP website. So thank you, panelists, for being here today. I really think you have so much to share, and I think our audience is going to really appreciate your remarks. Our first panelist is Kate Sapra. She's the director for the Division of Multi-Payer Models in the State and Population Health Group at the CMS Innovation Center. Our next panelist will be William Henderson. He is the Principal Deputy Director of Medical Economics and Analytics at the Maryland Health Services Cost Review Commission. And then our next panelist will be Pat Jones, Interim Director of Healthcare Reform at Vermont Agency of Human Services. And last but certainly not least is Robin Lunge, who is the co-chair of the Global Budget Technical Advisory Group at the Green Mountain Care Board in Vermont. So we're going to start with Kate at the Innovation Center, and she's here to share details about the AHEAD model's hospital global budget and primary care investment goals, and we'll speak about how they fit with other core elements within the model. And then we will turn to our state experts, our payment and delivery reform leaders from Maryland and Vermont, and they're going to share some of their experience to date. I did want to note, like all states, officials in Maryland and Vermont are weighing a lot of information to determine whether they'll participate in the AHEAD model, but both states are currently engaged in a hospital global budget and primary care investment. So their experience, challenges, and considerations may be useful as others consider pathways to health system transformation. So that's what they'll speak about today. Just a few logistics before we turn to our speakers. Given the number of registrants for today's webinar, we're going to be using the Q&A function for all questions. The Innovation Center has staff on hand to provide answers to as many questions as possible throughout the webinar. We also encourage you to write in questions for Maryland and Vermont, but we're going to hold off until all the presentations are completed before posing them to our speakers. And we'll try to get to as many as we can within the time that we have allotted for this webinar. One question that is always posed: will the recorded webinar be posted online? Yes. So I can answer that affirmatively. Within a few days, NASHP will post an archive of the webinar on our site. So with that, I'm going to turn it over to Kate Sapra from the Innovation Center to kick us off. Kate.
Thank you so much, Hemi, and thank you to the staff at NASHP and to my co-presenters today. I know them well from our work together at the Innovation Center, and I'm really excited to hear from Vermont and Maryland. So I'm going to go as quickly as I can through my portion so that we can hear the state perspective. Let's go ahead and move on to the next slide, Allison. So as many of you on the call are aware, AHEAD is a multifaceted model which really seeks to hold states accountable for total cost of care growth, achieving primary care investments, and achieving population health and health equity outcomes over a longer time horizon than what we've typically tested at the Innovation Center. So 8 to 9 years, really in recognition that we're going to need early investment to be able to see that more sustainable cost growth and the population health outcomes that we seek in the long term. Today, I'm going to be talking about two of the tools that CMS is offering to states in order to help them achieve those targets. So the hospital global budgets and primary care ahead. Let's go to the next slide. And the next one. All right. So as we've been talking with states about global budgets, we have found that it's very helpful to set out a definition at the beginning. So what is an ahead hospital global budget? For us, the hospital global budgets are built bottom up from past net patient revenue within the facility, both inpatient and outpatient, including hospital outpatient departments. So this really reflects a hospital's historic experience. This baseline will be fixed for the duration of the model with annual adjustments for inflation, demographic changes, and service line changes each performance year. So while the baseline is fixed, the budget is dynamic and changes every year. It will be known prospectively in advance of the year what that budget is to provide the stability and predictability to hospitals. Really, we aim to support hospitals in transforming care delivery and shifting utilization to primary care and community-based settings where appropriate through the incentives and flexibilities that hospital global budgets provide. Another question that we often get is, why would a hospital want to participate in this model? And we think there are a few reasons. One, in particular for AHEAD, we're providing initial investment to support hospital transformation in the early years of the model. So as I noted at the beginning, we recognize that early investment is needed in order to see the long-term outcomes that we desire. The second is increased hospital financial stability and predictability when the revenue is decoupled from fee-for-service. And I do want to recognize that this is a very different business model than the current fee-for-service that most hospitals are operating under. And, Maryland has a decade almost of experience now, and I'm really looking forward to hearing more from William. There's an ability to share in savings from reduced potentially avoidable utilization and more efficient care delivery. Again, this is part of the shift in thinking about where does margin come from under a hospital global budget. It really is in coming in even below the hospital global budget and keeping the savings below that. There's an opportunity to earn upside dollars for improving health equity and quality while contributing to population health in the hospital's community. And I'm going to go into this in a little bit more detail. There's also the potential to use waivers to support care delivery transformation and engage non-hospital providers in that transformation. And again, this is all specific to the AHEAD model. There's also an opportunity to participate in learning opportunities that will facilitate success under the global budget. So hospitals don't have to do this on their own. We've recognized that this is a really big change, and we at CMS want to support hospitals in their care transformation journey. Let's go on to the next slide. So I do apologize for how busy this slide is and hope you'll be patient with me. But I wanted to get to each of the payers under the AHEAD hospital global budgets. Whoops, if you could just go, thanks. So for the global budgets, each payer is creating the global budget and paying it to hospitals individually. So we at CMS will make the Medicare fee-for-service global budget payments to hospitals, and then Medicaid, Medicare Advantage, commercial payers will each have their own global budget that they're paying to hospitals. Let me go into a little bit more detail on Medicare fee-for-service. Participating states with statewide rate setting or hospital budget authority, who happen to be on this call today, may develop their own hospital global budget methodology in accordance with alignment principles that CMS will outline in the notice of funding opportunity that should be forthcoming next month. States are not required to have all payer rate setting to participate in AHEAD. That's really important to know. States that don't have these authorities will use the CMS designed global budget methodology, and I'll be talking about that in a little bit more detail today. This global budget will be implemented in the first performance year. Now, shifting to Medicaid, the state Medicaid agency is responsible for developing the Medicaid-specific global budget methodology, again in alignment with principles that will be outlined by CMS in the Notice of Funding Opportunity. CMMI and the Center for Medicaid and CHIP Services will review and provide technical assistance on the Medicaid methodology. So again, states don't have to do this on their own. There's going to be support from CMS. Any Medicaid methodology will need to go through the approved normal regulatory processes through CMCS. And these global budgets must be implemented during the first performance year. And then on commercial and Medicare Advantage, we believe that commercial payer participation can maximize hospital participation in global budgets by bringing a greater portion of hospitals' revenue under this population-based payment. So participating states will develop a methodology with, again, alignment principles outlined by CMS, and at least one commercial payer must participate in global budgets by performance year 2. This could be a state employee health plan, qualified health plan, basic health plan. So we're fairly flexible there. All right, now we can finally go to the next slide. So which hospitals would be eligible? Acute care hospitals and critical access hospitals are eligible to participate. CMS does not require participation. Hospital participants must be Medicare enrolled facilities in good standing, and they must be located in the participating state or in a sub-state region if a state chooses to implement this on a sub-state basis. In states that enact enabling legislation, we will also include rural emergency hospitals. Something to note on the state side, at least 10% of Medicare fee-for-service net patient revenue within the state or sub-state region must be under a hospital global budget by the start of the first performance year in order for the state to remain in the model. This increases to 30% by the start of the fourth performance year. Again, all of this will be detailed in the Notice of Funding Opportunity. Next slide. So let's get into a little bit more detail here. So as I mentioned, there is historic revenue that forms the base for the global budget. We will calculate this for eligible hospital services. Again, this is only for the facility services, not for the professional services. We will combine 3 years of historical data and weight more recent years more heavily. Then we apply the annual adjustments to calculate the current performance year budget and to reflect hospitals' accountability for quality and reducing avoidable utilization. I'm going to go into these in a bit more detail on the next slide, but overall, these include baseline adjustments and trend adjustments, as well as the AHEAD-specific adjustments. That gives the global payment for the next year. So this is known in advance of the performance year. It's fixed, and CMS will make biweekly payments to the hospital in place of fee-for-service claims. Now, those claims must still be submitted for quality and monitoring purposes. They simply will not be paid. The global budgets also take the place of cost-based reimbursement for critical access hospitals. The full methodology will be shared as part of hospital recruitment activities. And we are hopeful to have the full methodology available in the early part of 2024. Let's go to the next slide. So let's talk a little bit more about these AHEAD-specific adjustments. The transformation incentive adjustment is an upward adjustment for hospitals to invest in enhanced care coordination in the first 2 years of the model. So this is really CMS saying, we know it's going to take additional resources. We want to give them to hospitals. By offering it only in the first 2 years of the model, it also acts as an incentive for hospitals to join early. We will have clinical and social risk adjustment, likely based on HCC, the ADI at both the state and national level, dual eligibility, and Part D low income subsidy status. We have a health equity improvement bonus, which is an upward adjustment based on the hospital's performance on disparity sensitive measures focused on closing gaps in healthcare outcomes. Quality adjustments will continue as normal in the CMS quality programs for the PPS hospitals. And new and ahead, we will offer an upside option for critical access hospitals to reward them for the high quality care that they provide to beneficiaries. There's also a total cost of care performance adjustment, which is upward and downward based on the total cost of care for beneficiaries residing in the hospital's service area. This is phased in over time, and this is really to get hospitals thinking about care that's provided along the continuum, not just within the hospital walls. There's also an effectiveness adjustment, which is based on a portion of the hospital's calculated avoidable utilization. Again, this is phased in over time, and a hospital retains any savings beyond that adjustment. Let's go to the next slide. And I know this one is busy, but I thought it would be helpful to see at a glance all the different adjustments and when they're phased in, as well as understanding where there are flexibilities for critical access hospitals and safety net hospitals. I'm not going to spend a lot of time on this because I've already gone over it, but I'll just pause for a second to let you take it all in. Let's go to the next slide. Now we're going to shift to primary care. Primary care ahead is designed to be flexible and to meet states where they are. In primary care, we really want states to take the lead, and we are going to be aligning with each state's Medicaid primary care goals and really bringing our Medicare dollars to the table to reflect the increased investment that we believe primary care needs in order for states to achieve their total cost of care growth targets. We're also seeking to align payers. And again, this is by asking the state to take the lead, wanting to support advanced primary care through behavioral health integration, care coordination, and addressing health-related social needs, and broadening participation by ensuring that FQHCs and for the first time rural health clinics can participate. We've also committed to introducing tracks with additional risk and capitation in the future. Let's go to the next slide. Primary care practices may voluntarily participate in order to receive the enhanced primary care payment. They must be located within the state or sub-state region, and they must participate in the state's Medicaid primary care APM. Hospital-owned practices are only eligible to participate if the affiliated hospital is participating in the global budgets in that same performance year, though we do have an exception for FQHCs and RHCs. Next slide. I think this is my last one. Just want to talk a little bit about the payment in primary care ahead. So the enhanced primary care payment is on average $17 per beneficiary per month for attributed beneficiaries, and there is no minimum number of beneficiaries that must be attributed to a practice in order for them to participate. A small portion of this payment is at risk for quality performance. And as I already noted, practices must participate in the state's PCMH or other primary care APM, and they must meet specific transformation requirements, which will be aligned across Medicaid and Medicare. These dollars are flexible and can be used to invest in infrastructure and staffing to perform advanced primary care. All right, let's go to the next one and see if I was right. I think that's it. I'm all done.
Thank you so much, Kate. We really appreciate that overview. I'll also just recognize that that's a lot of information to take in. So we really appreciate you pausing at certain points to help users digest and our audience take in those slides. As we've already noted, we are going to post a recording of this webinar. We are getting questions in, and there are some answers to those questions, so keep them coming. Now we are going to turn to Vermont and Maryland. It was already noted by Hammy that Vermont and Maryland are going to be speaking to their existing or current efforts and are still weighing whether they are going to move forward with the AHEAD model, but just to underscore that their current efforts are being shared as an opportunity to learn from their experience with other health transformations. So I'm going to walk us through some questions that the states are going to help answer. So the first one, what are your state's overarching health system transformation goals? Because we know states really root these efforts in goals, and help us understand Maryland and Vermont's primary reason for pursuing these efforts. Let's start with Maryland, and I will welcome William to help talk us through these.
Thanks, Maureen. We can go ahead and go to the next slide. I'm actually going to spend very little time on this one. This is just a history. Maryland does come in with a long history of somewhat unique approach to hospital rate regulation, and the global budgets are ultimately built on that, although I don't think that's an essential precursor. But this just goes through that history. I think the more important slide is the next one, if we could go to that. So this is kind of how we think about this, right? We don't think of global budgets sort of as an end unto itself, but rather a platform on which we build a broader set of goals. And really the nice thing about global budgets, right, is that they do align the hospitals, who are, the largest players in any healthcare ecosystem, provider ecosystem, with the idea of maximizing the health of the community rather than simply being a sick care system. And so that aligns that sort of very fundamental piece. And given how influential hospitals are in the provider markets these days, right, you're really bringing a lot of providers along when you bring hospitals along. And then we wrap this into those other two layers, which is a broader payment and delivery system reform, where we are looking to build other initiatives that get to the non-hospital providers and value-based programs on top of that. And then we work very closely with the Department of Health, with the rest of state government, with other local agencies to align initiatives that address health and health equity, but all built on that platform that we have this sort of big player in the hospitals aligned with those goals. So hopefully the hospitals, the providers, the state are all pulling in the same direction. I think the next slide, I'll turn it over to Vermont.
Great.
Fantastic.
And next slide as well. Thank you.
And Vermont, I'll just say right before you get started, we know that Vermont does not have a hospital global budget in place at this time, but we know that Vermont has been pursuing that and has made a lot of efforts to invest in primary care. So thank you for being on this and sharing those efforts with us.
Great. Thank you, Maureen and William. So, to answer the question of what problem were we trying to solve, this won't be a surprise to anybody on this call, but, there were two really major areas that we had concern about as we were embarking on healthcare reform. The first was cost growth, and in particular, that graph on the left shows the percentage of gross state product devoted to healthcare spending over time. And you can see, the blue line is Vermont, orange is the US, Both were increasing rapidly from the mid-90s on. Vermont was increasing more rapidly than the US as a whole, with 18.5% of gross state product being devoted to healthcare spending in 2017. And then we had concerns about health outcomes as well. The impact of chronic disease on death, and the costs of treating chronic disease. And then in the mental health and substance use disorder arena, we have had death rates for suicide and drug overdose that were higher than the national average. So big concerns there as well. In terms of our really high level overarching goals, again, this won't be a surprise to anyone on this call, but the triple aim has really served as our North Star in our healthcare reform efforts. So improving the quality of care, improving the health of the population, and reducing growth in cost of care. Next slide. So we, like Maryland, have a long history of evolving healthcare reform here in Vermont. And we've been successful in partnering with CMS on a number of payment and care delivery reform efforts. And just to reinforce what William said, the point of payment reform is really to improve care delivery and improve those outcomes. So back in 2008, our Blueprint for Health Advanced Primary Care program was initiated, and it became a multi-payer program with Medicare participation in 2011. Some positive results in terms of cost and quality there, and we've linked to the evaluation. Then in 2014 to 2016, we began looking at accountable care organization models, and we had support from CMS through our state innovation model grant. And so we did an upside only shared savings program for Medicaid and commercial, and again, saw some positive results there, particularly in terms of costs. Our current model, our most ambitious, from 2016, when we signed the agreement, first performance year was 2018, until the present day, is our Vermont all-payer model. And again, looking at spending for Medicare beneficiaries, we have seen some positive evaluation results there as well. Looking ahead, we are looking at exploring implementing pilot Medicaid global payments programs. Our current model is a all-inclusive population-based payment for Medicare Part A and B type services on a per member per month basis, but we're looking to explore broadening that beyond an attribution model for Medicaid, maybe beginning as early as 2024. And then in 2025 and beyond, really looking to see how we could shift even more dollars into prospective payment, and really focused on stabilizing our rural healthcare system. Next slide. This is a logic model for our current all-payer model. The theory here is that we wanted to test payment changes to see if they resulted in transformation in care delivery, and then the end result being improved outcomes. And those outcomes that are noted here are actually part of the quality framework in our current all-payer model. They're the overarching population health goals of improving access to primary care, reducing deaths from suicide and drug overdose, and reducing prevalence and morbidity of chronic disease. And the state is held accountable to those goals in the model. Next slide. And this says just a bit more about the current all-payer model agreement. It was originally for 5 performance years through 2022. We are in the first year of a 2-year extension, which will take us through 2024. And Vermont and CMMI are discussing the potential for extending through 2025. There are 3 signatories on the Vermont side to the agreement: our governor, Phil Scott, the secretary of the Agency of Human Services, and the chair of the Green Mountain Care Board, as well as CMS. And the accountability for the state is in 3 areas: total cost of care. There's accountability for scale, so the percentage of lives that are attributed to the ACO. And then, as I mentioned before, those population health outcomes with corresponding quality of care targets. So a total of 22 measures altogether related to those overarching population health goals. Next slide.
Thank you both to both of our state representatives, grounding us in sort of the goals and the reasons for moving in this direction. Again, I'm sure this came through, but recognizing that it was both costs and ensuring quality and improved health outcomes, I think is really important to remember as we continue our discussion, which now is going to be focused on your state's approaches, both to the hospital global budget and to investing in primary care. So for this, because Maryland is actively engaged in a hospital global budget, we wanted to turn to you first, William.
Thank you. So this topic certainly one I can talk about a lot, but we tried to sort of digest the key pieces into a couple of slides here. This first slide, right, is really just a compare and contrast, right? A traditional fee-for-service system on the left. You have units and cases, you get paid an amount per unit, and that generates your revenue, and the hospital maximizes their revenue by doing more units, and is working from an uncertain revenue base throughout the year, which, you know, I think can particularly be critical when you get into hospitals in more rural areas who potentially have a shrinking volume base, and therefore are continually in a sort of death spiral of having shrinking revenue and having to find new and different ways to offset that. So it gives both that certainty to hospitals, which, like I said, I think is, you know, probably most important in the more rural areas, but also it does encourage more volumes to create more revenue, as opposed to a global budget where you determine a population-based revenue base. You then update that for inflationary and population changes, but not specific services delivered. And that generates a revenue target for the year. The hospital knows that at the beginning of the year, they can have some certainty around that. And just generating more units does not create more revenue. And that connects back to a point I made in my original one and has been reinforced, right? That I think, to me, the key thing this does is it changes the question the hospital has to answer from a financial point of view, from one of how do I do the most services to my community to how do I create a healthy community while delivering the necessary services. And I think, given the size and influence of hospitals in our healthcare system, having that major player on board with that kind of thinking is really why we would want to do global budgets. So we go to the next slide. This goes to all the adjustments we do. It's, you know, obviously not as simple as we would all love it to be, but I think, you know, we found this to be very manageable. I'll walk through each of these. I will say, Kate covered a very similar slide early, and you can almost one-for-one map the adjustments she talked about in the AHEAD model to the things that we have built up over our 10 years of doing this. And so, you know, I think we've got a pretty good list of things that one needs to think about here, and the methodology will be sound in that sense. It's not like we don't have some experience that led us to these things. So top left, we start with a fixed revenue base. We then do an adjustment for inflation that's based on a global inflation factor similar to that used in IPPS, typically around 3%. We then make some population and volume adjustments. So we use, first of all, we use state level population trends to adjust for shifts in the size of the overall population. And second of all, we do look, and this is much more critical in the more urban areas, we do look at shifting service mix. So if a particular service has moved from hospital A or to hospital B, we would make an adjustment for that. Less common in more rural areas where you may only have one hospital in most services. We then do make adjustments for quality and for potentially avoidable utilization. So this rewards hospitals for high quality services and also rewards hospitals who avert avoidable utilization. There are then some boundaries around efficiency and capital use. So the Maryland system does require that the Health Services Cost Review Commission, my agency, keep revenues aligned with costs. And so that's really this efficiency approach, which sort of provides some boundaries to make sure that all the other mechanisms are sort of still keeping the hospitals at a reasonable point from a revenue point of view. Capital, there are potentially additional adjustments should the hospital be, for example, building a new facility and that's been necessary. We do have a small set of special funding programs, which is where we use the global budgets to say, okay, we really need hospitals to invest more in X. For example, that was used during COVID to encourage investment in COVID vaccination programs. Then there are a few other fees that we build in. We actually use the global budgets to help sustain our HIE. So Maryland has a fairly sophisticated HIE, and that's partly because we are able to use the global budgets to direct investment there. And then the Medicare performance adjustment is our total cost of care adjustment. Kate referred to a total cost of care adjustment, and that's effectively what that does. In our case, that adjustment right now is just Medicare, so hospitals can earn more or less money depending on their performance in total cost of care. And then we have a set of programs that reward additional care transformation and alignment with the physicians. And those can also provide supplemental or reductions in the global budget, depending on how successful the hospital is in implementing those programs. So what this really does here is take the framework, a very simple idea that a hospital should be paid a fixed amount for providing care in their community, and builds into it, all the unfortunate complexities that are out there in a way that we think, generates a fair and equitable system that adequately funds hospitals. Trying to think, could go to the next slide. So the other topic here was our investment in primary care. So we have a program that's called MDPCP. We have about half of the primary care providers in Maryland participate in this program. And it's a tracked program. Track 1 was some additional payments in order to implement some additional advanced primary care mechanisms like expanded hours, risk stratification. Those are listed there. And then over time, we have moved the practices into track 2 and track 3, each of which add additional requirements, but also additional payments, and also then align those payments with the performance of the practice so that the practice performance is, financial performance is aligned with their overall performance in outcomes and in cost. And so now gradually all of the practices are moving to either track 2 and I think ultimately to track 3. But it did provide a glide path, right? So that we didn't have to go to a practice de novo and say, go from doing nothing with this thing to track 3. And we thought that was pretty important in getting the practices and bringing them along. And we'll look to sort of continue to refine those mechanisms. On the right, you can get a sense, the specific payments. I'm not in the scope here going to go through each of those, but basically it's a combination of performance-based and flat fee payments, dissimilar to the proposed HEAD program. And the HEART payment is one I think we're particularly interested in. That's a payment that does provide additional payment for practices that are serving underserved or beneficiaries that meet certain requirements in order to enhance the care in that area. I think that's my slides.
Great, thank you. Maureen, do you need to jump in or can I just
No,
go
I
ahead?
don't. Please go ahead. Thank you so much.
Great. Hi, everyone. Robin Lunge from the Green Mountain Care Board. So Vermont has also had a hospital budget regulatory process in place since the 1980s. Ours is not a payment mechanism, so we don't regulate the underlying payment methodologies at this point, but we do set a net patient revenue target for each hospital, thus establishing a budget that they are expected not to exceed each year, and have enforcement in order to ensure that if a hospital does exceed that budget, that we in some way figure out how to bring them back into alignment with that cost trend. I think what that has the challenge that has posed is there is no floor, so a hospital can always fall under their budget. So it's really been designed as a cost containment mechanism, not sort of a balance between cost containment and sustainability, which has been an ongoing issue since right before 2018, 2019, and through the pandemic. We have several small critical access hospitals, and like others across the country, are seeing some financial challenges in that sector. So we also do look at some key financial indicators. We look extensively at the underlying cost structure and expense structure of the hospitals as part of that review. Next slide. So in 2022, the legislature passed Act 167, which created several different components for how we move forward with addressing the sustainability issues in our hospitals in Vermont. And part of that was looking at the development of a hospital global budget. And so I'm going to speak a little bit to that now. We have a technical advisory group that we established in January of this year and expect to run through at least January of next year. And if we go to the next slide, that group is broad. It includes hospitals, payers, consumer advocates. Really, we tried to choose the focus in the members based on having a level of technical expertise, because we're trying to get into the weeds. And the charge of the group is to really come up with recommendations for a conceptual and technical spec for a multi-payer Vermont hospital global budget program. So as you can see, this slide will also mirror both Kate's and William's prior slides about the components that we're looking into. So defining the scope of the budget, for example, in the head model, there is a discussion around the budget focusing on inpatient and outpatient. Because of our hospital structure, our hospitals also, many of them have, for example, professional services owned by the hospital. So we're looking at perhaps evolving into a more broad definition of what would be included. I'm not going to go through obviously all of these, but basically same basic premise: calculate a baseline budget based on prior revenue, and then use adjustments as a way of moving that amount forward over time. We are expecting that we will have a full sort of discussion of all these by January, and then look forward to comparing that to what's included in the notice of funding opportunity in the head model. So I'll turn it over to Pat now to talk about primary care.
Great. Thank you, Robin. So I want to say a few words about Vermont's efforts in primary care. The Blueprint for Health is our signature advanced primary care program. Again, started in 2008, the multi-payer component, including Medicare participation, was fully fledged in 2011. And so the way the program is set up, Vermont is divided into 13 health service areas. And so each of those health service areas receive multi-insurer funding. So it's legislatively mandated for our largest commercial insurers, Medicare and Medicaid. And that funding provides for two services. One is it provides additional funding for primary care practices in the state that have become recognized as patient-centered medical homes. And that's more than 130 practice sites, and that's the vast majority of our primary care practices that have voluntarily participated in this program. And then each health service area also receives funding to support a multidisciplinary community health team. And the idea, there's some central staff, and then there's staff that might be embedded in primary care, but it can be social workers, mental health clinicians, dietitians, but wraparound services to really support people with complex health and social needs. And that community health team framework has really served as a springboard for additional supports to our communities. And in particular, Medicaid has provided additional funding to those community health teams to stand up our hub and spoke system of providing treatment for people with opioid use disorder, and particularly medication treatment and mental health and nursing services. So there are 87 program sites, many of them in primary care practices around the state, but the community health team really serves as the mechanism for funneling that Medicaid funding. There's also a pregnancy intention initiative that has been stood up in about 40 practices statewide. And then most recently this year, right now, we are rolling out additional Medicaid funding for an expansion pilot statewide for the blueprint that supports universal screening for mental health, substance use disorder, and health-related social needs, and then staffing to do brief intervention and then referral to treatment when needed for people who screen positive for certain conditions. There's a foundational statewide infrastructure that really underpins the health service area approach, and that includes state funding for program managers in each health service area. There's a cadre of quality improvement facilitators that work directly with practices on everything from PCMH recognition to workflow improvements to quality improvement initiatives, and that has proved to be quite successful as well. There is, population data and analytics that underpins the blueprint, and then learning health system opportunities. So opportunities for leaders to come together and learn. Just a couple of other things on primary care. I want to note that under our current model, the Accountable Care Organization has rolled out what they call the Comprehensive Payment Reform Initiative, and that has provided capitated payments for independent primary care practices that choose to participate. And we've seen really good uptake in that model since it was implemented a couple of years ago. And then in addition, Vermont has, through the Green Mountain Care Board, actually, Robin's organization, we have looked at primary care investment. So the percentage of healthcare expenditures devoted to primary care, and have worked with other states on how to best define that. Sounds like an easy concept, but there's a lot of complexity there. So that's a snapshot of our efforts in terms of advanced primary care and primary care investment. So I think we're moving on to the next question now.
Yes, and the next question is about measurement. So how do your states measure whether these reforms are actually meeting your identified goals? I think for this, I'm going to turn to Vermont first.
Sorry, should have been ready to jump off mute. I think I'm taking this one, Pat, right?
Correct.
Okay, so Vermont's goals are measured through the statewide targets that were established in our all-payer model. So we have, similar to the AHEAD model, a total cost of care growth target for all payers and also for Medicare. For healthcare spending at the all-payer level, under our agreement, we have been looking to keep the average increase in costs to 3.5% and no more than 4.3%, which was established based on Vermont's historic economic growth over the period of the model. So initially that was a 5-year model extending to now a couple of extensions. And then we also have a Medicare savings target, which is 0.2% below national Medicare savings, again, measured over the life of the agreement. And just given the time, I won't go through where we are yet, but we expect to be on track for meeting those targets by the end of the performance period. Next slide. Pat, do you want to briefly touch on the quality framework?
Certainly. So the next 3 slides, and I won't go into great detail on them, but I'd mentioned earlier that there's those 3 overarching goals that are in our current agreement. And underlying those are 22 quality measures that the state is held accountable for in that agreement. And the way that it's set up is that some of the measures are process milestones. They presumably support achievement of healthcare delivery system quality targets, and then in turn would support improvement in those very ambitious population health outcomes. If you go to the next slide, I think I'll just focus a little on that. This is such an area of concern and interest in Vermont, and I think nationally. And so we really tried to thoughtfully identify measures that would support reductions in deaths from drug overdose and from suicide. So some of these, they'll look familiar. They're HEDIS type measures or Medicare measures. But, looking at screening for depression and follow-up plan for a positive screen, the number of Vermont residents receiving medication-assisted treatment for opioid dependence, and then looking to decrease the number of morphine milligram equivalents dispensed per 100 residents. So those are the process milestones. And then those healthcare delivery targets, a couple of HEDIS measures around increasing initiation and engagement of alcohol and other drug dependence treatment, improving follow-up after discharge from the ED for both mental health and substance use disorder treatment, and then reducing rate of growth in ED visits for those conditions to support people getting care in the community, all leading to an effort to reduce deaths from suicide and drug overdose. Each of these 22 measures has an associated target and accountability for the state. So you can skip over the next slide and we can move on to the next question, or to William, I guess.
Yep. William, you're up.
Okay, thank you. I think I'm going to take a moment. There's a couple of questions about MDPCP in the chat, so I will try and answer those. So the first is about how the payments flow. So the payments are not made by the HSCRC. So we actually don't make any payments. We direct other people to make payments. So in the hospital space, we do that. We do not do that in the physician space. Those additional payments are made by CMS under the program. So that's how those payments get made. The second question was about if there's if there is key lessons on getting practices to participate. I'm with the HSCRC. I'm slightly one step removed from our primary care program that's run by the Department of Health. But from where I sit, I would say there was 3 things. One is we work very closely with the state medical organization, and they've been huge supporters of this and really worked to get physicians at the table under this and other programs. The second is there is more money in this. The state pays more, in the state, primary care physicians can access more money by participating, right? So there is an incentive to participate, and then that is paid for through the savings targets that we have to achieve. And I think the third thing is that staged implementation I talked about. We didn't sort of jump straight to an advanced model on day one. We really gave practices a chance to build up to that. Looks like, Maureen, you want to maybe skip to the lessons learned, given that we're running up on time here.
You know what I think we'll do? And we worried about this. There's just so much that these states are doing with these reforms. We worried we were going to run out of time. I will just flag that we do have slides that each state, Maryland and Vermont, pulled together to share their lessons learned. And we will post those slides along with others with a recording of this webinar, but we are getting questions from states about what is needed ahead of time to move forward with some of these reforms. Some specific questions are, did Vermont and Maryland need enabling legislation to be able to make some changes for a pathway to move to these reforms? The other is infrastructure such as state funds. And so are there more FTEs that you need? So again, I know I'm jumping the gun and we're skipping some slides. They will be posted, but just if you could each spend a minute to talk about the infrastructure that needs to happen or that you all put in place for these reforms. I may look to Vermont and then we'll have Maryland round us out. Pat, do you want to take this?
Yeah, I can go ahead and start, and Robin, please jump in. But I will say that in terms of legislation, as I mentioned before, we do have legislation for the Blueprint Advanced Primary Care Program that mandates participation from commercial insurers. So that has been, needless to say, very, very helpful. In terms of infrastructure and staffing, we do have a central team that helps implement the Blueprint for Health. And there's about 7 folks on that team who work in a variety of areas and are very, very busy with that program. And then, the Green Mountain Care Board, to a greater degree, and to some degree, the Agency of Human Services and our Medicaid program definitely have staff members implementing that all-payer model that we're currently involved in. Robin, what would you add to that?
Just on the GMCB side, I would say when we began, we do have legislation at the very highest level around the all-payer model agreement. It doesn't go into detail or specifics about total cost of care or anything like that. It just simply sets out some general legislative goals that would need to be thought of as the state entered those negotiations. The hospital budget process has been in statute for a very long time. The team there is very small. We have basically two people plus a third supervisor, and supported by analytics and a part of a lawyer. And then we did have to add staff to our analytics team in order to do the federal reporting.
Thank you. And William, I know I'm asking you to hurry, but would you mind sharing a little bit about the infrastructure in Maryland?
Yeah, I mean, the story is pretty similar in terms of legislation to Vermont. We have long-standing legislation that dictated the hospital rate setting and the all-payer participation. And then there was some very high-level modifications made to that to bring it in alignment with the total cost of care model when that was implemented. And then, yes, so the Health Services Contribution Commission, my agency, that comes from the original rate setting work and was established and is actually funded through the rates themselves. So we have a staff of about 30, I think it is, that are responsible for all our legacy rate setting work, plus the work we do with CMS on the total cost of care model.
Thank you so much. And again, I just want to thank CMMI. I want to thank Vermont and Maryland for pulling together such thoughtful presentations. There will be more information that NASHP will be able to provide some state-only space for states to digest some of this more. We look forward to tapping some experienced states to helping us sort of walk through how others should be preparing and weighing these different considerations. And just really appreciate the opportunity. I'll look to Kate. Any last words to close us out?
Thank you so much for the opportunity to present more about AHEAD, and thanks to states for sharing your experience. I will just say, I really think this is where the magic happens when the federal state partnership is in action. I hope you're all leaving this as energized as I am. And just to say that we have an open door right now. The NOFA will be coming out very soon, but until that time, please do get in touch with us. And the AHEAD mailbox is always a resource. So thank you so much. And thanks, Maureen and team, for hosting us.
Thank you all. I hope you have a great afternoon. Bye-bye.
Thank you, everyone.